If you encounter a patient who has been fasting or starving with a metabolic acidosis, you need to consider ketoacidosis. In the presence of normal or slightly raised blood glucose, we call this euglycemic ketoacidosis. This is a particular problem with patients who have type 2 diabetes who have been prescribed sodium glucose cotransporter 2 inhibitor drugs. These are also known as Flozins. These drugs inhibit glucose reabsorption in the proximal tubule of the kidney. In the absence of ingestion of carbohydrates, these patients can rapidly develop ketoacidosis. This tutorial looks at how these drugs work, how these patients develop ketoacidosis, and how to manage it. Ketoacidosis, Part 3. Euglycemic ketoacidosis in the setting of diabetes and SGLT2 inhibitors or Flozins. Welcome back. In the previous tutorial, I introduced the concept of euglycemic ketoacidosis and two situations in which you may encounter it: alcoholism and in starvation. And there's a lot of overlap between the two. Most alcoholics who present ketoacidotic are actually in a state of starvation, having discontinued alcohol a day or two before it occurred. The management of both alcoholic and starvation ketoacidosis is similar. I discussed the treatment options, the complications of treatment, and the concerns that one might have about refeeding syndromes. In this particular tutorial, we're going to talk about euglycemic ketoacidosis in the setting of sodium glucose cotransporter 2 inhibitors or Flozins, and the treatment and prevention of euglycemic ketoacidosis in this setting. Let's start with a clinical scenario. You're called to the surgical ward to see Elaine, who is a 59-year-old female. She presented with abdominal pain, melena, anemia, and a background of type 2 diabetes with metabolic syndrome, and she's been treated with a combination of perindopril and amlodipine 5 mg and 5 mg, lansoprazole once a day, atorvastatin at night, and a combination of metformin and canagliflozin 100 and 150 mg BID. Now, Elaine had a CT of her abdomen, and this showed an apple core lesion in her ascending colon that is consistent with colonic carcinoma. She was fasted for surgery for 2 days and given 100 ml per hour of sodium lactate solution. This is Hartmann solution or lactated ringers. Her medicines were continued, and then after 2 days waiting for surgery, she became acutely unwell on the ward. At that stage, this is what her blood gas looked like. Although the pH looks like it's in the normal range, that's because there is full respiratory compensation for the acidosis. Although the patient was hyperchloremic at the time, the anion gap was not considered particularly wide with a normal level of lactate, and nobody was getting terribly excited about this patient, but she continued to deteriorate. I'll make a major point here. Have a look at her base excess. It's -10 with a bicarbonate of 13.8. So her bicarbonate is 10 milliequivalents per liter below where it should be. There is a significant metabolic acidosis going on here. Now at time 2, a couple of hours later, the patient has a pH of 6.97. She's compensating as well as she can, but her base deficit is now -30 milliequivalents per liter. The cause of her metabolic acidosis is twofold. She has hyperchloremic acidosis with a chloride of 116 and ketoacidosis with ketones of 4.4 millimoles per liter. Remember, that's just beta hydroxybutyrate. There is also acetoacetate present. The hyperchloremia is the major driver of the acidosis, but what's underlying all of this is ketoacidosis, and it's likely that this patient's ketones were high at the very beginning at time 1 and possibly when she arrived in the hospital, but nobody thought to check the ketones. So let's look at euglycemic ketoacidosis. This patient has so-called euglycemic ketoacidosis due to continuation of her diabetes medicines despite being fasted for a prolonged period of time for surgery and receiving no external calories during that period. Remember, she was getting Hartmann solution lactated ringers. There's really no calories in there. Even though this particular patient had high blood glucose, I prefer the term euglycemic ketoacidosis because the term diabetic ketoacidosis usually triggers the brainless application of the frequently nonsensical local DKA protocol in which the unsuspecting patient is drowned with several liters of potentially toxic isotonic saline solution, whether they are dehydrated or not, hypo-iso or hyperchloremic or not, hyperosmotic or not. I'll return to the management of this particular patient when we talk about hyperchloremic acidosis, but I will point out that this patient started with a very high chloride, and this was a major component of her metabolic acidosis. But why did she develop such bad ketoacidosis? This is not merely starvation. To understand how this patient got to the place that she's at, we need to look at the processes behind most cases of type 2 diabetes that we see today. And it all goes back to the 1980s. When Gerald Reaven noticed a particular constellation of symptoms in high-risk patients that combined central obesity, insulin resistance, hypertension, impaired glucose tolerance or type 2 diabetes, hyperinsulinemia and dyslipidemias, and he called it Syndrome X. This was subsequently relabeled Metabolic Syndrome, and that's the term we use today. This combines central obesity defined by a large waist circumference, 37 inches in a male, that's 94 centimeters, 32 inches in a female, or 80 centimeters, plus one of two things, hypertension, hyperglycemia, or dyslipidemia. So two of the three of those. What causes metabolic syndrome and why it's important is because a very large number of the population now have this. They are at advanced risk for all kinds of cardiovascular disease. And it seems to be resultant from a combination of insulin resistance or hyperinsulinemia and widespread pro-inflammatory activity in the body. Now this is associated with advancing age, so you don't get metabolic syndrome if you're overweight at the age of 18, but you certainly have it in your mid-30s. There are certainly genetic factors, and there may be other issues such as a change in the gut microbiome. The ingestion of large amounts of food, particularly ultra-processed foods rich in refined carbohydrates in excess of metabolic requirements, results in the development of central obesity, often called visceral obesity. This apple-shaped obesity pattern is problematic because visceral fat is metabolically active and it generates a host of different pro-inflammatory cytokines known as adipokines that promote inflammation. The intake of large amounts of carbohydrates results also in hepatic steatosis or fatty liver, and this is caused by high levels of circulating insulin that is driven by all of the sugar in the diet. That fatty liver is highly resistant to insulin. Consequently, as high glucose intake persists, blood insulin level rises, and this is known as insulin resistance. And that results in a vicious cycle of adipogenesis and hepatic steatosis. The patient becomes fatter and more insulin resistant. The accumulation of fat in and around the islet cells and the loss of the ability of insulin to suppress circulating glucose levels results in hyperglycemia and eventually type 2 diabetes. Simultaneously, the activation of inflammation within adipose tissue associated with alterations in the relative levels of adipokines and insulin resistance results in a prothrombotic and atherogenic state, increasing the risk of cardiovascular and further metabolic disease. The big picture here is the villain is glucose. Glucose and other refined carbohydrates make the liver fatty, and the fatty liver is the motor of metabolic syndrome and type 2 diabetes. There is a vicious cycle of insulin resistance and steatosis that precedes type 2 diabetes. There is increased free fatty acid production and release, reduced leptin, and a pro-inflammatory state. So high glucose intake results in a fatty liver that results in insulin resistance and failure to suppress blood glucose and type 2 diabetes. Type 2 diabetes is treated with insulin sensitizers and exogenous insulin. That does nothing for the fatty liver. It increases adiposity, and the continued high glucose intake results in increasing insulin resistance, and this in itself is a vicious cycle. Because of this, the drugs that we use to help the patient with type 2 diabetes, all they do is suppress blood glucose, but not all of the complications of both obesity and diabetes mellitus. High glucose intake is the problem, and patients with type 2 diabetes generally don't stop eating glucose. It's an addiction. It's part of the food industrial complex. Patients can't avoid it. So it makes sense that if you could, you would block the absorption or increase the elimination of glucose. And if you increase the elimination or block the absorption of glucose, then this cycle stops, the fatty liver resolves, the adiposity should resolve, and the complications of type 2 diabetes should reduce. And the mechanism is to increase elimination through the kidneys by blocking the reabsorption of glucose in the proximal tubule using a group of drugs known as sodium glucose cotransporter 2 receptor antagonists, SGLT2 inhibitors, that are also known as Flozins, in the same way as HMG-CoA inhibitors are known as statins. This is what I'm going to call them, Flozins. Flozins, unfortunately, like a lot of modern drugs, have almost unpronounceable names. There are 3 Flozin drugs licensed in the European Union: dapagliflozin or Farxiga, canagliflozin or Invokana, and empagliflozin or Jardiance. And you will notice that those trade names bear no resemblance to the generic names. If you see the generic name, the Flozin part will be very obvious to you. Be aware that there are combo drugs out there that are being prescribed by general practitioners that combine those agents with metformin. So dapagliflozin plus metformin is Zigduo, canagliflozin plus metformin is Volcanamet, and empagliflozin and metformin is Synjardy. Confusing, right? Let's look at how Flozin drugs work. We're going to look at the kidney. We're going to zoom in on the kidney and look at the tubules. We have afferent and efferent arterioles, the glomerulus, the proximal tubule, the loop of Henle, the distal tubule, and the collecting ducts. And I'm going to simplify things like this. We're going to zoom in and look at the glomerulus and the proximal convoluted tubule. Circulating sodium and glucose are filtered at the glomerulus and then rapidly reabsorbed in the proximal convoluted tubule. This occurs because of the presence of various transporter proteins that are lodged in the wall of the tubule. The most important one with respect to glucose is the SGLT2 sodium glucose cotransporter or symporter 2 protein that is responsible for reabsorbing approximately 90% of filtered glucose, up to 180 grams per day. The transporter complex is also responsible for some of the sodium reabsorption that occurs. When a Flozin drug is administered, it binds to the sodium glucose cotransporter 2 receptor and prevents binding by both sodium and glucose. This results in wastage of a large amount of glucose and a lesser amount of sodium in the urine. That results in glycosuria. A surplus of chloride is reabsorbed, resulting in raised plasma chloride. So you have sodium and glucose, principally glucose, being excreted in the urine and chloride being reabsorbed. This will have effects on biochemistry. Hyponatremia does not occur because other sodium reabsorptive pathways, for example, this one where sodium is reabsorbed with lactate and ketones via a monocarboxylate transport protein, are still working. And so there is a mild natiuresis, but plasma sodium levels remain relatively normal. So SGLT2 inhibitors, or Flozins, have the value that they massively increase urinary excretion of glucose in patients with uncontrolled carbohydrate intake, in particular type 2 diabetics. The glycosuria results in reduced blood glucose, better glycemic control, reduced adipogenesis, and steatosis. These agents also appear to have a role in the management of congestive heart failure, possibly due to mild natiuresis, and in a variety of different nephropathies. And we're going to see a lot of these drugs over the next 10 to 20 years. I think they're going to be used for lots and lots of diseases. One of the drawbacks of using these drugs is the urine becomes sweet, and sweet urine increases the risk for urinary tract infections. There is another problem. If a patient is fasted or they're starving themselves, the glucose that is produced by gluconeogenesis continues to be wasted if Flozin drugs continue to be administered. This results in volume depletion and hyperchloremic acidosis. There is increased glucagon and adrenergic activity, increased free fatty acid breakdown, and increased ketosis, leading to ketoacidosis. Now, although SGLT2 inhibitors reduce blood glucose, they also have a direct impact at reducing ketone excretion. So you have a situation whereby the blood glucose is falling and continues to fall, the ketones are high, and you can't get rid of them. In the case of Elaine, who developed ketoacidosis secondary to SGLT2 inhibitors, these drugs were continued after admission. She was given non-glucose containing resuscitation fluids, became ketoacidotic, developed confusion and tachypnea due to her acidosis. So this is euglycemic ketoacidosis, not diabetic ketoacidosis. The blood glucose may be normal to mildly raised. The patient usually has good glycogen stores, so symptoms may not manifest for 12 to 36 hours. Lactic acidosis is unusual, but hyperchloremic acidosis is common. Although volume depletion may occur, the patient rarely needs more than 2 liters of resuscitation fluid. Ketoacidosis rapidly responds to dextrose and insulin, but bicarbonate may not recover as fast. So the management of this form of euglycemic ketoacidosis, often in diabetic patients, is to commence intravenous dextrose and insulin immediately. The dextrose feeds the Krebs cycle and allows for both gluconeogenesis and aerobic glycolysis. The insulin suppresses the production of ketones and feeds the Krebs cycle. Ketoacidosis is rapidly reversed. The patient does need to be resuscitated, but they should be given a balanced salt solution, not isotonic saline solution, if volume depleted. This fluid may be Hartmann's or lactated ringers or Plasmolite or Normasol. If the chloride level is very high, for example, more than 120 millimoles per litre, I would suggest that you consider at least using sodium bicarbonate, that is, giving the patient some sodium without chloride, increasing the strong ion difference. If you look at this picture of the patient in question, you will note that this patient had a plasma ketone level of 4.4 on admission to the ICU. Time is represented as you go to the right of this picture. You can pause this particular slide and have a look at the different numbers, but you will see the pH is 6.99 with a very low PCO2 and a base deficit of nearly 30 on admission. However, you will note that within 12 hours of this patient being admitted to ICU with severe ketoacidosis, that is completely resolved. But the metabolic acidosis itself was very slow to clear because a significant part of this acidosis was caused by hyperchloremia. And the chloride level had yet to resolve. This is a picture of the patient's chloride, and the time in this particular picture goes from right to left. So you can see that the initial chloride was 114, but within a couple of hours it had gone up to 126 because the patient had been fluid resuscitated with isotonic saline solution and was already hyperchloremic on admission. How do we avoid euglycemic diabetic ketoacidosis? Patient education is paramount. No food, no Flozin. If you're not going to eat, don't take the drug, particularly if the drug also contains metformin. Doctor and nurse education is paramount. It takes 5 half-lives for SGLT2 inhibitors to stop working, so it must be discontinued in advance of surgery. If the patient is being fasted and they have had these drugs recently, they must be given glucose orally or glucose-containing maintenance fluids. These fluids should be continued post-op. So this is the situation where you're going to run a glucose infusion all the way through the operation and into the post-operative period. Now let's look at another clinical scenario. You're called to the PACU. The patient you're called to see is Jerry. He's a 67-year-old type 2 diabetic with post-op femdistal bypass and toe amputation. Jerry has a background history, aside from his type 2 diabetes, of prostate cancer, COPD, hypertension, psoriasis, and cirrhosis. He's being treated with metformin, aspirin, talmosartan, amlodipine, rovustatin, and Invokana, which I already told you is canagliflozin. His base deficit is what you've been called for, and it's -10 post-op. As a rule of thumb, if the base deficit is -5 or more, always check ketones. So this is his blood gas. You'll see that the pH is 7.35, and that on the surface doesn't look bad, but he is hyperventilating. His PaCO2 is 3.5 kilopascals. His base deficit is 10 millimoles per litre, and his ketones, as measured by our protocol, is 6.6. So that's pretty impressive. His lactate is also 2. Despite the normal range pH, this patient has lactic, keto, and dilutional acidosis and hypoalbuminemic alkalosis. But the ketoacidosis is a major problem, and the patient was commenced on dextrose and insulin. The ketones are at the very bottom of the screen. His ketones started at 3, then they increased to 6.6, and over the next 8 hours, the ketone levels diminished to minimal. They had vanished completely by 24 hours from diagnosis. So let's have a look at the perioperative management of patients treated with Flozins. The first thing to do is identify that the patient is being treated with these drugs. Suspect that all type 2 diabetic patients are on these drugs until otherwise proven. Check their admission records. If you're not sure, call the GP and make sure you know the local trade names for these drugs, but also the combo drugs, particularly with metformin. If you know that they're on Flozins, they should be stopped 3 days pre-op, but you should also assume that those patients forgot to stop the drugs. If you suspect that these drugs are still on board, for fasting, give a 5% dextrose infusion or give hypotonic saline in dextrose or Maintenolite. Check the ketones before and after surgery. Administer a glucose-containing fluid, such as what I've previously mentioned, post-op. Don't restart these drugs until the patient is eating and has established normal dietary patterns. Let's review this tutorial. In this tutorial, I discussed euglycemic ketoacidosis. I discussed metabolic syndrome and type 2 diabetes, and why Flozins or SGLT2 inhibitors are being used now and how they work. Why Flozins are associated with ketoacidosis, how to treat euglycemic diabetic ketoacidosis associated with Flozins, and how to avoid euglycemic diabetic ketoacidosis in this patient population. In the next tutorial, I'm going to move on to discuss hyperchloremic acidosis. I'm going to discuss the causes of hyperchloremic acidosis and explain why you should be avoiding isotonic saline solution most of the time. I'll see you then, and I guarantee you'll learn something. So that was ketoacidosis associated with Flozin drugs. I hope you found it useful. If you did, please subscribe to my channel or follow me at ccmtutorials.org and give me some likes and make some comments. I'll see you soon.